Hello, everyone, and welcome to today's show. We are joined today by Dr. Jeffrey Singer. He is a currently practicing general surgeon down in Phoenix, Arizona, and a senior fellow at the Cato Institute. And he's here to talk about the physician shortage here in Idaho and what we could do about it. So, Dr. Singer, thank you for joining us.
Thank you for having me.
And so tell us a little bit more about your background and your position at the Cato Institute.
Well, I've been a general surgeon in private practice in Phoenix for over 40 years now, and I've always had a deep interest in public policy. So for the last 7 years, I've also been a senior fellow at the Cato Institute in the Department of Health Policy Studies as I've scaled back my practice, so I'm practicing sort of part-time at this point.
Gotcha. And so Idaho is experiencing a pretty substantial physician shortage. The most recent data I saw from the Cicero Institute actually is projecting upwards of about a 1,700 physician shortage by 2030. And Idaho just recently had some bad news, actually. We've fallen from 49th to 50th in the nation as far as physicians per capita. And so what is driving this physician shortage? It seems like it's a national issue, and Idaho is, as a rural area, is just experiencing the brunt of it.
Yeah, it is a national phenomenon. In fact, the Health Resources Services Administration defines what they call HPSA, HPSA. That's Health Professional Shortage Area. And 98 million people in the United States live in what they define as health professional shortage areas where there's not enough clinicians, particularly primary care clinicians, to meet the needs of the population. We have an aging population. We have a growing population. We also have more and more health care practitioners leaving the workforce, retiring earlier than they thought they would. Not just physicians, but nurse practitioners, physician assistants, and there are not enough entering to replace those that are leaving. So between those two factors, we have sort of a perfect storm. Idaho, even before the COVID pandemic, was ranked 50th. Now it's gotten worse because the pandemic actually made a lot of practitioners who couldn't practice for a couple of years anyway because their practices were pretty much locked down. A lot of them decided, well, maybe this is a good time for me to retire. So more of a loss of healthcare practitioners for the population.
Gotcha. And actually looking at the data from the American Medical Association, about 30% of Idaho's physician workforce is 60 or older. So they're also a fair chunk of our workforce is kind of entering that retirement age as well. And so what have been the solutions so far on the part of either the government or hospitals to try and rectify this physician shortage? What are we currently doing?
Well, right now, unfortunately, not a lot. What we need to do is remove barriers that most governments have in place, mainly on the state level, that prevent various of what we call mid-level healthcare practitioners from practicing to the full extent of their training. So several states recently there's still plenty of states that don't allow nurse practitioners to practice independent of a collaborating physician, but about 28 states do now allow nurse practitioners to practice independently. That helps. Some states are allowing physician assistants to set up independent practices. My state of Arizona just recently passed legislation that allows PAs to set up their own practice, but they have to have, an agreement with a physician who is available on call if they have any issues. But they're not supervised. They just have somebody that's available to help them out. And a number of states are allowing this new concept, which some people call them assistant physicians, but sometimes that gets confused with physician assistants. Some states call them associate physicians. Basically, they're like apprentices, which is how most doctors became doctors prior to the 50s or so when we started having the formal residency track. So these are doctors who've graduated medical school. They have their doctorate degrees. The way things work in this country is, and this is with every state, in order to get a license to practice as a physician, you have to have graduated an accredited medical school. Yeah, you have to pass all three parts of the standardized U.S. medical licensing exam. Normally, you take part one halfway through med school, part two right before graduation, and part three is you take a year after. And most states require you to have just completed 1 year in any postgraduate training program, or we also call them residencies. So it doesn't have to, you don't have to complete a residency, but you have to do 1 year. And then you can get a license to practice. And since you haven't completed a residency in any specialty, you're not a specialist. So you're what in the old days we used to call GPs or general practitioners. Since the 1950s, the Medical Association and the Association of Graduate Medical Education kind of teamed up and came up with a system to get into a residency program. And this has created bottlenecks. So the way it's worked since the 50s, when you're in your last year of medical school, you start looking at places you want to go to do your residency. And you set up interviews, just like if you're interviewing to go to college. And then you fill out a form and you list in order of preference your top 10 choices. And meanwhile, the residency programs have interviewed people as well, and they have their top 10 choices. And using algorithms, a computerized system basically tries to match the top choices of the students with the top choices of the residency program, and that's called the match program. The problem is it only occurs once a year. It's on the third Monday of March, and that's called match day. And then there's match week, where afterwards, if you didn't get into a program, you could try to find if there are any vacancies and see if you can possibly wiggle your way in there. So that's the way it's been. And then if you don't get into a residency program, you have to wait an entire year to start all over again. So what's been happening for the last several years, and it's really complicated, but mainly the residency programs have become very dependent on government funding of residency programs. You know, they have to pay the salaries of the residents and the teachers and all that. It didn't used to be that way, but for the past several decades, they largely depend on mostly federal and some state money to fund these residency programs to hospitals. And in the 1990s, Congress actually, in a Budget Reconciliation Act, put a cap on how much money they're going to spend on this. So now we have more graduates than we have slots. And on average, about 7% of MD medical school graduates and 8% of DO medical school graduates find themselves left out, and they can't get into a residency program. So they're in this kind of state of limbo where not only do they owe $300,000 in med school loans, and they can't get a job to start paying it back, but they have to wait a whole year to get into a to try again and get into a training program. And in the meantime, they're going to be kind of losing a lot of the skills and knowledge because they're not putting it to work. So that's a real problem. So actually, the state of Missouri was the first one to address this, and in 2017, the legislature there passed a law that created a category called assistant physicians. They thought, why don't we take these doctors who haven't completed a year of residency? The way they made their law is it's not just you didn't get into one, but maybe you got into one and they were terrible in their training, or they were abusive, and you didn't. So you could, alternatively, you could come to work for a licensed primary care practitioner, providing it's in an underserved rural area of the state, sort of like they're apprenticed, or kind of actually sort of like a resident. Because if anybody's been in a hospital and seen by a resident, they know the resident's not there with a doctor by their side. The resident is taking care of the patient and introduces themselves as a resident, and they're an MD or a DO, and they report to their supervising doctor, who also checks in with them. And any major thing, like in the case of a surgical resident, you're not going to be able to take a patient to surgery without, number one, getting that approved by your supervisor, and number two, having the supervisor supervise you doing it. So it's the same concept. So since you didn't get into a residency program, or you didn't complete a year of residency, you come to work with a licensed physician. You don't have in Missouri. You don't have to be in that physician's office physically. You could be in your own office seeing patients, maybe on the other side of town, provided that you have an agreement with that physician on a 24/7 basis, where that physician's around to answer questions, to supervise you, and that physician is responsible also for checking in and auditing your charts. So this way, you're taking someone who's got all these years of training and got a doctorate degree, and you're giving them a chance, first of all, to make a living. Second of all, they're taking care of patients. We have patients who can't get into doctors, so you're adding another clinician to the workforce. And at the same time, they're also getting more experience, just like they would be if they were in a residency program. That's been going on since 2017 in Missouri. Here in Idaho, they passed a law, something like that, a couple of years ago, where they instead of calling them assistant physicians, they call them bridge physicians.
And so I actually want to just backtrack just a little bit because the viewer might not know what it actually takes for somebody to go through medical school and actually become a doctor. So what does that process look like? How do you become a doctor under the current system? And then how does that contrast with the assistant physician model in Missouri?
Okay, so to become you mean a licensed doctor?
Yes, to become a fully licensed doctor.
So to become a fully licensed doctor, first you got to graduate from an accredited medical school. Gotcha. And you have to have done 1 year of any postgraduate training program, okay, any residency program. Take part 3 of the U.S. MLE, and then you apply for a license. That's how it was for me. I came to Arizona. I went to medical school in New York. I came to Arizona in the 70s. I did to be a general surgeon, it's a 5-year residency program. At the end of my first year, I passed part 3 of the USMLE. I applied for a state license. I got it. So as far as the state of Arizona is concerned, I was already licensed as a general practitioner. I couldn't call myself a specialist because I didn't finish my specialty training yet, but that helped me actually moonlight. So I would work on days when I was not working as a resident. I would work part-time in like urgent cares and emergency rooms to help supplement my income. I had a young family, and I was providing care in the community as a GP. Now people may not know this, but no state requires doctors to get certified as a specialist in order to get a license. So once I completed my 5 years of general surgery. Then I applied to the Board of Surgery, the American Board of Surgery. It's a private, nonprofit organization based in Philadelphia. And they have an exam you take, and they want to see how many surgeries you've done and all that. And then you can get board certified as a specialist. And you could, advertise yourself to the community as I am certified by the American Board of Surgery as a surgeon, as a specialist. But no state law requires you to do that. So when you have a license to practice medicine, as far as the state licensing boards across the country are concerned, you have a license to practice medicine. So, for example, I'm a surgeon. If I decided tomorrow, I think I'm going to switch and practice psychiatry, that's totally okay. I could just change the sign on my door because psychiatry is part of medicine. So I have a license to practice medicine. Or maybe I want to do OBGYN or pediatrics. I could do any of those things. Now, whether or not I'll be successful is a separate story. But as far as the state licensing board is concerned, all you have to do is 1 year. So, for example, let's say you do 1 year of a pathology residency, which I believe is a 3-year program. So that during that year in pathology, these are the doctors who look at tissue specimens under slides and run the labs and do autopsies. So they don't take care of live patients. They don't examine people and interact with people. They're very important, of course. So let's say at the end of my first year of a pathology residency, where it's been a year since I got out of medical school, since I examined or spoke to a live patient. I passed part 3 of my USMLE. I get a license to practice. I can go out and practice as a physician. I could even, say I'm a psychiatrist, even though I'm not board certified as a psychiatrist because I didn't take the residency and take the exam. So that's the way it is today, everywhere.
Gotcha. And what people don't realize is it's actually the market that's those checks and balances to make sure that the people that are taking care of you in those specialties are qualified to do so. Can you speak on that a little bit?
Yeah. So getting back to the psychiatry example. So I've been practicing surgery for 40 years. So and by the way, Idaho, Arizona, most states require, in order for you to keep your license active, you have to take at least 20 hours of continuing medical education a year. As long as it's an accredited education program, they don't care what it's in. So obviously, if you're a surgeon, most of the time you're taking education classes in something that deals with surgery. But I've been doing that for 40 years. I don't need another class on how to repair a hernia. I could give the class. But last several years, I've gotten very intrigued by psychiatry. So I've been taking a lot of those required 20 hours in psychiatry courses. So I decide, I need a change. So I think next week I'm going to change the sign on my door. I'm going to become a psychiatrist. I just need a new challenge. Totally legal. I'm a licensed medical doctor, so that's part of medical practice. I change the sign on my door, and then I realize, well, I need to get some patients. So I go to the hospital where I've been doing all my surgery, and I say, I'd like to get psychiatric privileges here so that if a patient gets admitted, let's say, a suicide attempt, and you need a psychiatrist to consult, you can call me. So they refer me to the hospital credentials committee, which is made up of members of the medical staff. This is the way it always works. And the credentials committee is going to ask me, so where'd you do your psychiatry residency? I said, no, I didn't do that, but I've taken a lot of continuing education classes in it. And I say, well, before we give privileges in psychiatry, we require you to at least have completed a psychiatry residency program and preferably to become board certified. So come back when you've done that. So that was a disappointment. So then I get back to my office and I say, I better notify my different health plans. I want to be put on their panel as a mental health provider so that way I can get some patients. So I contact, Blue Cross and all the other ones, and I asked them if they could put me under their list of mental health providers. And they asked me the same questions. Where did I do my training? And they say, well, you have to have done at least completed an accredited residency, preferably board certified, to be on our panel. But we'll be happy to keep you on our panel as a surgeon because you've done that. So then I realized, I better notify my malpractice liability insurance company that I'm doing psychiatry. So I call them, and they ask me the same questions, and they say, well, we're happy to continue covering you for any malpractice arising from surgical problems, but not for psychiatry. So if you get into a lawsuit over that, you're on your own. Okay, so meanwhile, I could still practice, and most psychiatrists people have dealt with this know more than 50% don't take insurance anyway. They're cash only. And it's a lot of office practice. You don't need to go to the hospital. So I could still do this. But who's protected me from the public? Who's done the vetting? It wasn't the licensing board. The licensing board, I could do this. All the licensing board did was make sure that I graduated from an accredited medical school. I took at least 1 year of a residency, and I passed Part 3 of the exam. But who's protecting the public? Well, the hospital credentials committee, who doesn't want any trouble at their hospital. They don't want incidents. They don't want reputation tarnished. The health plans, who likewise don't want to get reputation of having bad doctors on their panel, and they don't want to get sued. And the malpractice insurance company, who doesn't want to assume risk for somebody who, based on their knowledge, is probably a big risk. So all of these private sector actors looking out for their own concerns, which is their reputation, their ability to attract business in the community, and their liability risks, they're the ones who are actually protecting the public, not the license board. How many times have we heard about licensing boards reinstating the licenses of doctors who were suspended for, let's say, sexual assault, but they get their license back? So they're not, the licensing board is protecting doctors from new competitive entrants into the field. I mean, for years, the licensing boards were fighting such fields as nurse practitioners and physician assistants because that's competition. So.
Gotcha. And so now pivoting to the solutions for the physician shortage and trying to address those. So what is an assistant physician in just a succinct definition?
Well, it's a an MD or DO, a medical doctor who has completed medical school, which on average is 6,000 hours of clinical training. Separate from the didactic when they're learning biochemistry and anatomy and all that, and they have not completed that 1 year of residency. So instead, they're kind of doing a semi-residency. It's like an apprenticeship where they're working, they're taking care of patients just like a resident would, and they're supervised just like a resident would be by a doctor in an independent practice who's assumed responsibility. It's important to mention that the doctor's not forced into this relationship. So if this would-be assistant physician doesn't impress the doctor in terms of their skills or their judgment, the doctor may say, I don't want to get involved with this, taking responsibility for supervising this assistant physician. That's another check, like we were talking about earlier with the malpractice insurance in the hospitals, et cetera. It's another check. So anyway, they work and take care of patients, and they have 24/7 collaborative agreement with a licensed, experienced physician. Now, in most cases, in the states that have passed this, they require that the physician be engaged, the assistant physician be engaged in primary care. And they usually want them to be in underserved areas where there's not enough primary care clinicians around. Whereas, for example, physician assistants or nurse practitioners, they could go into different specialties. You have psychiatric nurse practitioners, you have physician assistants who just do orthopedics, who just do neurology, depending on who they work with. I have a physician assistant in my surgical practice, so he is very experienced in things like making post-op rounds and assisting in the operating room, but it's very narrowly focused. But in the case of the assistant physician or associate physician, they're doing primary care just like a family doctor would. They actually are practicing family medicine. And then usually, like in the case of Missouri, you could renew that license indefinitely. Now, in Idaho, unfortunately, they just allow you to do that for 1 year. And in my opinion, that doesn't address the primary care shortage problem. All you did was buy a year for that unfortunate medical school grad who couldn't get into a residency program, but the bottleneck still exists. So after that year, if that doctor doesn't get into a residency program, he's out of luck, or he's found one in another state, but doesn't do anything to address the bottleneck in the flow of doctors coming out. In addition, cutting it off after 1 year, that person now has one more year of experience. Why do you want to take this person who's got an extra year of experience after medical school and say you can't take care of patients anymore?
So what's the path for an assistant physician to get a license as of right now?
As of right now, if you didn't get into a residency program in Idaho, there are 5 other states too. Those other states require that you tried to and didn't get into a residency program in the match. Missouri just says you didn't complete one, so they give you more flexibility. Well, after that, you apply to be an assistant physician, and the state medical board grants it. And then depending on the different states' laws, like I say, it could end after 1 year, it could end some states after 3 years, or in the case of Missouri, you could renew that indefinitely. I would argue so if 1 year of, say, a pathology residency plus passing Part 3 of the USMLE qualifies me to get licensed as a general practice doctor and go out in the community, then why wouldn't, say, 3 years of being an assistant physician under the supervision of a licensed family practitioner plus passing Part 3 of the exam and taking continuing education credits, why wouldn't that be good enough for me to go out in the community and be a GP? I would argue that we should allow assistant physicians after a set period of time, and we could argue how many years it should be and all that, but after a set period of time, it's got to be at least as good as a 1 year of a residency program, and we need doctors.
Right. And Idaho actually has a bill on the docket this year that's supposed to do just that. It's House Bill 418, and it's supposed to allow our bridge physicians, the people in our bridge physicians program, the time to continue to practice as bridge physicians, and then offer a pathway, a direct pathway to licensure without having to go and try and reapply for a residency program and continue to feed that bottleneck. And so naturally, the question that's going to come from the public is that these people, they didn't go through a residency program, and they've been told that the residencies are the way that we ensure that the doctors have the training that they need to go out into the community and practice. And so are these people that are going through the assistant physicians programs, do they have training that's commensurate with those who are going through a residency program?
Well, they don't have training in a specialty, but they have training in general primary care after a few years. Like I mentioned before, we could argue whether it should be 2 years, 3 years, 4 years, but after a set period of time when you've been taking care of people, providing primary care services, you're taking because of all states require you to take a certain amount of continuing education credits per year. So you're also having to take those continuing education credits to keep yourself educated. Like when you're in a residency program, there's time taken out of the day where you go to a lecture. And you also have to pass that same exam that all other licensed physicians have to pass. So after a certain period of time, it has to be the equivalent of 1 year of a residency program. It's also important to understand that while you're being an assistant physician, you're under supervision. So we're already comfortable right now with nurse practitioners practicing under collaborative agreements with physicians, and with physician assistants practicing under a collaborative agreement under supervision of a physician. So why should we not be even more comfortable with somebody who's had even more training? They got a doctorate to be able to practice under the supervision of a licensed physician.
And you said something really important earlier, and I want to make sure that it gets emphasized too, is that the way licensing laws work right now in most states, including Idaho, is that you don't have to complete your residency to get a general practice license in those states. And so you only have to complete that first year and then make sure that you pass the final step of the United States medical licensing exam. And then you can go and practice as a general practitioner. And so what's your experience? I've heard of doctors, they've been able to moonlight and supplement that low residency income that we all hear about. And is that your experience too?
Yeah, the most recent numbers I was able to get was from about 2020, 2021, from the Kaiser Family Foundation. There are roughly 200,000 adult primary care physicians in the United States. It's less than a quarter of all physicians in the United States. Then another type of primary care clinician is a pediatrician, so that's why I'm talking adult. Gotcha. And out of them, is about 6,500 to this day are general practitioners. They never went and completed a residency program. They just went after 1 year. Gotcha. And many of them, you get 40 years of experience administering care to primary care. Now, remember, you're a primary care physician, so when you're supposed to be able to, screen out things that are complicated, and if it looks like it's complicated where this needs somebody who's specialized in this, well, then what you do is you refer them to the specialist. Now, if you're in a rural area, you may have to refer them into the more urban area where they have those specialists around and a hospital with those specialists. But for the most routine, everyday things, preventive care, routine illnesses, and also working up things that might be more complicated and need to see a specialist. That's what primary care doctors do. They're the people that most patients interact with on a day-to-day basis. You don't want to need a specialist. A specialist is when the problem's getting complicated.
Right. So building on what we were talking about earlier, and you had mentioned at the very beginning where a lot of these residencies are government funded. And so what people don't realize is that medical residency programs are actually very centrally planned, and they're kind of doomed to failure when they're trying to address the physician shortage. So what we have is a situation where it's a very reactive system. The government notices that we're short primary care physicians, or we're short in one specialty, or we're short in another specialty. And so then they go and they go and fund more residency programs to fill that gap. And the way I'm looking at these assistant physicians, especially if you offer an alternate pathway for them to gain full licensure from that hands-on experience, you're creating a program that's a lot more flexible than the current residency system. You can't, small practices, smaller than your standard big city hospital, or the places that normally get accredited for those residency programs, will be able to train the next generation of physicians to take care of their patients. They'll know that patient population. They'll be able to go to more rural locations, because they have that flexibility for the market to decide what the need is and where the needs are. Do you agree with that? What's your perspective on the flexibility?
I think it's a very good point, because when you're dealing with funding residency programs, you have what some economists call the knowledge problem, where how do you know how many residency slots you need? So, and not only that, but so sometimes you could overshoot and have a lot of vacancy slots, for example. You could overfund or you could underfund, because you're asking people to guess what the market's going to want. And on top of that, it's hospital-based, and it's costly, because the hospital argues that, well, we need all this money for one resident, because not only are we paying the resident's salary, but all the other teaching things that we do. And then it takes time. So if you wanted to address the physician shortage by funding more residency slots, it's still going to take 3 to 5 years for anybody to go through that residency slot. We're still going to be waiting. So here you have, by the assistant physician pathway, you have an immediate solution where, okay, you didn't get into a residency slot, well, you could do this. The other thing is, there's no guarantee that by funding more residency slots, you're going to get more primary care doctors. In fact, one of the reasons why there are so few primary care doctors is because a lot of medical students don't want to go into primary care because it doesn't pay as much as the specialties. So you may fund a whole bunch of primary care residency slots, and there are no people applying for them. Whereas anybody who's gotten into the assistant physician slot, it's understood that that's a slot to be a physician doing primary care.
Gotcha.
So it becomes much more likely, especially if you've been doing it for a few years and you're motivated enough to then want to get a full license and take the Part 3 of the USMLE, et cetera, there's a good chance you're going to stick in primary care, and maybe even in that rural community where you were given this opportunity because you've developed relations with the patients. One of the things that people in primary care tell me that they love about it is they develop relationships with the people in their community that are personal, and that makes it rewarding. So if you've been an assistant physician in rural Idaho, and now after 3 years you get to become a fully licensed general practitioner, the odds are you're not going to move away. And it's also important to remember, nothing ever prevents you from deciding one day as a general practitioner, I think I want to be specialized, and apply for a specialty residency program and do that. You could do that at any time in your life, but the odds are, if you've been doing this for a few years already and you're kind of settling into a community and getting comfortable with it, you'll stick with it.
Right. And it'll be interesting to see how all of this shakes out, especially with Missouri being a good pioneer of this concept. And then with this potential legislation coming through Idaho, it could reinvent how we procure new talent in the physician workforce. Dr. Singer, thank you for joining us today and helping us understand this issue and bringing in your wealth of experience from 40 years in the field, but then also your experience researching these topics at the Cato Institute. Please be sure to follow Dr. Singer on Twitter and to check out his other work in the links below in this video. Thank you for watching, everybody, and we hope to see you next time.